welcome back to the podcast. So this episode is a pretty exhaustive list of all the treatments that we found relevant for PTSD and trauma. These include both psychotherapies and medications. I've listed out the specific items that we talk about so that if you're looking for some specific therapy or medication, you'll be able to find it in our description. I hope that this sort of episode is helpful. We love to hear your feedback, so please send us a message or leave a comment in the reviews. I hope you enjoy. Welcome to the Good Enough Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. So now we want to talk about treatment, and the treatment is really twofold. Mainly with trauma, it's psychotherapy, but of course we have most of the time comorbid depression, anxiety, insomnia, nightmares, and so we have medications for those. But for trauma specifically, it's mostly through therapy, processing and reflecting, and being able to sit with the memory and the experiences that you've had. And so the general principle with psychotherapy for trauma is that you are trying to expose yourself to that experience and rewrite that narrative of your experience. And so initially when someone comes in, maybe they can barely talk about it, or they would start the story and then they would be crying, can't stop crying, they're shaking. And so there's an experience with recalling that trauma that's difficult, and over time we reduce those symptoms. Now on the other end too, you have someone that comes in and they are very flat, very monotone, no affect when they're discussing that trauma. And that's also equally difficult because, there is so much shutting down regarding that trauma that they're not able to access those emotions. And the tricky thing is you have to access them. You have to feel them in the moment, in the room. So the very first and foremost psychotherapy we want to mention is trauma-focused CBT. This has been used in little kids too, as young as 5 or 6 years old. But essentially, the idea of trauma-focused CBT is to rewrite the narrative and be able to share it with someone and be in control of your own story. It's usually pretty manualized, but I think you can really be creative with it. You can incorporate drawings, art, music, whatever form of expression. But it's a time-limited therapy session. It's about 12 to 16 sessions, and it combines exposure, cognitive processing, coping skills, delivered in 10 components, including psychoeducation, relaxation skills, affect regulation skills, cognitive coping skills, if you're working with kids, parenting skills, and then, of course, the narrative. In vivo, mastering the trauma triggers in the room.
I think that's such an important order that it comes in. We worked together in the emergency room before, and so sometimes we'll see people fresh off of a trauma, or that trauma plays some component in their presentation, even if it's a repeat of an incident that happened previously, or they have a trigger from something that happened previously. And a lot of people really resist the idea of therapy for exactly this reason that, well, I'm going to have to talk about it. I don't want to talk about it. I spend my entire life avoiding memories of this. Why do you want me to remember it? There's no good to come of that. And so a lot of times emphasizing that it's a collaborative process and the therapy doesn't move forward without the patient's consent. This is not something that you sign up for and you just get on the train and they take you all the way through, session 1 through deep trauma exposure. There's always discussion of where do you want to go next. It starts differently than the medical model. The medical model of taking a history is always, well, what happened? Tell me what happened to bring you in. And psychotherapy for PTSD doesn't always start that way. In fact, it almost explicitly starts out with ways to help you feel safe that are pretty generalizable to other situations too. So the goal of therapy, it's not always fun. But the goal is always to move you into a place where you're feeling better and to help you. A lot of times, just the coping skills, creating a safe place, learning how to deal with overwhelming emotions, whether they're related to trauma or not, that sense of control that really fundamentally is one of the biggest things you lose when you go through trauma can be very helpful.
Absolutely. The agency and the autonomy, and that's what trauma takes away, and you're giving that back to that person. I guess just dialing back a little bit too, oftentimes the reason people come in, I feel, is not necessarily, oh, I'm having like suddenly flashbacks or nightmares. It's almost always, I'm having these moments of dysregulation and I'm upsetting my partner, or you might not be able to focus at work or something like that. So even though it's about the past, the symptoms are in the present day. And that's usually what people come in with. With that being said, as you're saying, we have to start with what's in the room. So, if there is anxiety or physical symptoms you feel or whatever it is, you start there. That is helpful for people to kind of ease into trauma therapy because you're not having to like suddenly start talking about your childhood and what your mother and father did. You're talking about what are you experiencing today or yesterday? And that's an easier intro into
Yeah,
it.
absolutely. And I think it's an excellent point that what we would call in medicine the chief complaint isn't always the full story. And I've seen many cases of people coming in for an evaluation for ADHD or for an
Mhm.
evaluation for panic attacks, when really it is trauma once you get into figuring out what's happening. But you start with the symptoms that are concerning the person when they walk in the room.
Yeah. And sometimes I'll clock that this is very traumatic, but maybe if they're not wanting to go into it right now, I'll put it on the back burner.
Right.
Because it's you have to meet the person where they're at, and that's part of the giving agency.
Hmm.
So the other big treatment for PTSD is eye movement desensitization and reprocessing therapy, which is EMDR. This has been shown to be very effective, equivalent to that of CBT for PTSD. And this involves exposure sessions with a therapist where the patient will move their eyes side to side or use like a tapping rhythmic motion with the hand while recalling that traumatic event. And the idea is that the bilateral stimulation is thought to help connect brain regions that trauma has split apart. So it's interesting. EMDR, I've always thought that it's effective and helpful, but I think, throughout my training and talking to different people, people have opinions about EMDR.
Yeah.
What do you think, Dr. Kelly?
Yeah, I mean, I think it's funny to say it's controversial because it has so much positive evidence. I think the controversial part about it is not whether it's effective, it's whether the actual bilateral stimulation or eye movements are a necessary component of the treatment. And I've heard different things. There are people who say that it's absolutely the most essential part, and that even introducing that sort of in the context of other therapies can add efficacy. I've talked with other people who disagree and think that the cognitive work and the therapy itself, and sometimes even the relationship with the therapist and the creation of a safe space, is what really does the work. I am not trained in EMDR, so I feel like there's an extent to which I can't talk about it necessarily. I certainly know that it's no worse than any other type of therapy, that it may be superior, and that if it's something that is interesting, then I don't think there's a harm in exploring it. We'll talk about it later, but there are a couple of tools online that people can access to help them decide sort of which therapy seems most appealing. And I think one of the big highlights of EMDR that EMDR therapists will say is that the necessary component of the eye motion desensitization is that the person recall the trauma while they're doing the exercises, but they actually don't need to disclose that trauma to the therapist. That
Mhm.
a sort of linguistic based communication of the trauma, as opposed to literally every other type of trauma treatment, is not a necessary component of EMDR. So if that is really turning someone off and seems like a huge barrier to getting into therapy, this might be an interesting alternative.
Mm. Yeah, that is really interesting because part of, what trauma does is take that language away and you want to be able to regain that. But there's a place for that, if
Hmm.
it's really too much to tap into that right now verbally with someone and share it. I mean, it's extremely vulnerable to really recall the details to someone. So yeah, it can be a very much a safety net around that.
Yeah.
A couple other therapies that we like to mention. So there's also similar cousins almost of CBT, so cognitive processing therapy. It operates like traditional CBT, focusing on negative beliefs and fear. And I'm also not trained specifically in CPT, but they do focus more on kind of I would say, top-down
Hmm.
approach, kind of the way you think through it and then manage the reactions to those thoughts. There is another type of therapy called prolonged exposure, which is very key. This is oftentimes very effective, as you imagine, but it is extremely difficult. This actually reminds me of in residency, I worked with a veteran. And he was a combat veteran and obviously went through pretty difficult times with war and losing his friend in combat. But the what he was doing basically like every day or every other day was if you go in and talk to him, he will start talking about the same story
Hmm.
over and over. And in a way, he was like, doing exposure on himself. He was talking about it almost casually by the end of a month. So that made me think about how even though you might run into these people who talk about the same thing over and over and it kind of gets annoying and whatnot, but it's actually a really, really protective thing. It might be the one thing that kept him from losing a sense of himself. So,
Right.
yeah.
Yeah, he was rewriting, recrafting his own experience. And I think that's, how do I want to say this? I keep using the term interesting, and I don't want to distance the emotion because I'm sure it's not a fun process. I'm sure it's a painful process, but it's fascinating that he'd almost figured out how to do his own therapy to himself instinctually. Like that's fascinating.
Mm-hmm. Yeah, very much. And he didn't really care who he was talking to. That's
Hmm.
another thing that's important. I think there are relational aspects to therapy, but at the end of the day, it's your story you're rewriting.
Hmm. A couple of other therapies. There is narrative exposure therapy, which sounds very much like a combination of psychodynamic therapy and prolonged exposure therapy, but it's really going into the narrative itself of the trauma and how that fits into the person's life story and their core beliefs in terms of their experience to be a survivor and to integrate it into the rest of their life. And there are whole psychoanalytic psychotherapies based on language, with sort of healing the interpersonal relationships that may have been, or the patterns of interpersonal relationships that may have been damaged by the trauma itself, using those to lean on to heal some of the traumatic experiences. Um, the somatic therapy is one that I've heard more and more about and almost explicitly tries to get under the language part into the physical experience, into someone's body. And we know the body keeps the score. We keep quoting it for a reason. So for people who are physically focused or have a preponderance of physical symptoms, panic attacks, those sorts of things, I've heard from multiple patients that somatic therapy has worked faster, better, and really more than any other type of purely psychological or linguistic based psychotherapy.
Mhm. Yeah, so I've never learned about somatic therapy, in training, but it makes sense that you are working on how trauma is preserved in the body. And so there might be things people do like dance or yoga or even acupuncture. Just there's a wide range of things that you can address with somatic therapy. But it's really fascinating because there are five senses we all know, like see, hear, touch, taste, and smell. There are five senses. But there's actually a couple other senses. One of them is called interoception. And so that's your understanding of how your organs are doing doing. So like if you're hungry or if you're tired or if your muscles are aching, there's a connection between how your organs are functioning and how you feel. And so sometimes people might feel like, okay, if they're really, really stressed, they just don't feel hungry. They're completely ignoring those messages that your organs are sending to you. And so over time, then that can become its own monster of a problem, right? So eating disorders, a lot of times when there's trauma and you can't control your environment, you control what you put into your body. And then also headaches, migraines are so intricately related to trauma and abuse. Another sense that we have is proprioception. And this is your sensing of where your limbs are. So where your legs are, where your arm is. And sometimes with severe trauma, you can hear people say things that sound like depersonalization or derealization, and they just feel like they're out of body. They're not connected to their body at all. They have no idea where their limbs are. They're just kind of laying there. And so it makes sense that you can talk all you want, but then if you're not putting into practice some of these reintegration of your body with your mind, you can't practice it in the moment.
Yeah,
Yeah.
absolutely true. I think those can be unusual. I don't think a lot of people are used to experiencing depersonalization, derealization, disruptions of interoception and proprioception. And so when that happens, it can feel really scary. So
Mhm.
getting in touch with that, exploring that, recognizing that, and even using that as a tool to get past trauma can be very empowering itself.
Yeah. I remember because I really do enjoy psychotherapy, and I think especially trauma focused psychotherapy is something that's always like it's zebras. You think you've got it, and then there's always something. And I remember when a patient had started to dissociate, she was shaking her leg. Like you could see it start to show up, and then it was like aggressive, and her eyes were dazed, and she wasn't really responding super well. And in that moment, I think something that I felt was important to recognize was that I was freaking out. I was starting to feel like, oh no, did I do this? Did I trigger this? What am I going to do now? And so I think the other part of trauma therapy is so much about the therapist as well, just because you're in the room and you are put in a place that's pretty vulnerable as a therapist. And so I found that over the years, you kind of start out doing specific steps in a manual protocol, and then you start to realize the robotic nature of this doesn't really work. And you have to break that mold a little bit. And that's when you really start to see true improvement. So we lay out all of these therapies, but at the end of the day, I think how comfortable you are in the room with someone who could get agitated like that, you have to prepare as a therapist, because if you don't understand what triggers you, it could be harmful for the patient.
Yeah. I also think that's why most therapists have therapists,
Yeah.
because this is hard work, and knowing yourself can be the best way to make yourself into the best therapist possible, because the role of the therapist is one-sided on purpose,
Mhm.
right? That it's not sitting down with a friend and talking about your experiences, that the therapist has a responsibility to manage themselves in the room while they're doing the work with the patient. But you also deserve to take care of yourself. So, different therapists are different. But if someone says, I'm here because this terrible thing happened to me, the therapist is not going to say, oh, that happened to me too. Let me tell you, that was awful. It was a Monday morning, and that's not how it works. But you, as a therapist, deserve a space to do that. So having your own outlet can be essential.
Yeah, that's so accurate. I have to turn off that therapist brain when I'm talking to friends or family. I do bring up my personal experiences, but in therapy, that's not the point. I think if it's deliberate, like if you are trying to make a point or if you're trying to reach some goal, then disclosure works. But if it's coming out kind of impulsively, like in the moment without thought, that could be harmful, because now, the patient is trying not to hurt your feelings because you might have a past, and, it gets complicated. And so, exactly as you said, talking to a friend is so different from talking to a therapist. And that's why, even if you have like lots of really close friends that know a lot about you and can help you through tough times, it's still helpful to have a therapist who's objective, who's a third party, unrelated. You can basically talk bad about everybody in your life to your therapist. That is so important. That's a safe space that you need.
Yep, 100%. The therapist isn't supposed to be just a robot, right? Like you should be a person, but anytime you disclose, I mean, they even call it sort of therapeutic disclosure, that it's for a purpose, that it's for the betterment of the patient, that everything you do, the actions that you take in therapy should generally be guided by what's the best thing for the patient right now.
Yeah, absolutely.
So that's a bevy of options and a quick overview. There are a few ways to learn more about PTSD. The Veterans Administration has a pretty extensive website dedicated to PTSD, not surprisingly. And we've talked a little bit about this before, that people have opinions about the VA, but to their credit, they have a lot of free online anonymous resources. They've put a lot of evidence base and weight behind, and this is one. So there's a PTSD decision aid, which is sort of an interactive website where you click through what you're looking for, what type of experience you want to have, what your timeline is, and they'll recommend a therapy based on that. And then they also have a interactive comparison chart, almost like those if you're shopping for a product and you can put sort of two products side by side and the website will compare them in different
Yeah,
categories.
yeah.
It does that with different therapies. So
That's
you can look through like considering trauma-focused CBT and prolonged exposure, what are the differences between them in these different categories? And it'll help you line those up.
Hmm, that's awesome.
Yeah.
Yeah, we all need those comparisons. I use them all the time when I'm shopping for something.
Yep.
Yeah. So maybe we can talk a little bit about SSRIs.
Yeah, absolutely. So
Yeah.
you will see if you look at the comparison chart of PTSD that they do have even a column for medication. And so
Oh,
I think we should talk about the other side of treatment, which, as in most things in our field, involves either medication or therapy. So the evidence for medication in the treatment of PTSD, there are some caveats to remember right at the outset that the trauma itself and the reactions of the trauma a lot of times can be fueled by other underlying conditions. So we do know that people who have premorbid depression, premorbid anxiety are much more likely to develop PTSD after a traumatic exposure. So you can't work backwards. It's not the case that everybody who walks in with PTSD must have an anxiety or a trauma disorder predating their PTSD. But it's certainly worth considering. And a lot of times, the medications that we use in that class, in the antidepressant class, are really to help mitigate the underlying elevated anxiety or propensity to depression, as opposed to treating the trauma itself. But studies don't really work that way. You know, it's so hard in a study to tease apart what is the medication actually treating. Is it treating the underlying anxiety or depression, or is it treating the trauma? Because so many of the symptoms could be attributed to either. So, as a psychiatrist, as a therapist, we can tell for the patient sitting in front of us what our goals are and what we're treating. But if you take 500 people in a study, that you have going for 6 months and you basically assess based on surveys and interviews, it's so much harder to assess. Now, that is a huge caveat around the idea that SSRIs do work. And there is plenty of evidence that for the treatment of PTSD in the world of medications, SSRIs are definitely first line as medication options. What can be frustrating, I think, for patients and for providers is that SSRIs take time to work. That if someone comes in and says, I'm having these symptoms, I can't sleep, I can't focus, my life is a mess because of what's happening, and we say, well, let's start this medication at a low dose and we'll see how it's going in a month, that's frustrating. That's a hard message to take in. So even though they are first line, they're not necessarily going to scratch the itch of the person immediately. So a lot of times they're used in conjunction with psychotherapy, more effective psychotherapies, or sometimes other medications. And we'll talk about what medications are indicated and what medications are definitely not indicated, and to some extent even contraindicated in the treatment of PTSD. Both Zoloft and Paxil are FDA approved for the treatment of PTSD. There are multiple studies showing this. If anything, Paxil has slightly more evidence for efficacy, but again, that's in big studies of multiple people. That doesn't necessarily say it's going to be more effective for the person sitting in front of me, but it's a good consideration. Fluoxetine Prozac can be preferred by some, even though it's not officially FDA approved, because in studies, even though it doesn't carry the approval, the effect size of the treatment was larger than Paxil or Zoloft. So it's a bigger discussion of what does FDA approval actually mean versus the studies and how do you get it and all of that. But essentially, most of the SSRIs, if one works for a certain indication, most of them are going to work for that same indication. So now I will say that even with that larger effect size overall, the effect size of SSRIs for trauma symptoms is kind of small. It's smaller than therapy by itself, but it can be an excellent augmenter or an addition to the treatment of PTSD symptoms, especially if we know that there is a comorbid depressive or anxiety disorder that predated the trauma itself.
Yeah, it's so important to talk to a psychiatrist because you want to evaluate the full extent of what diagnoses are present and what's happening, what's going on. And I don't use Paxil very much because, it does have a lot of interactions with medications. It also is the most weight gaining generally. And so usually I think we stick to sertraline or Zoloft and fluoxetine or Prozac. So we're saying it might take a month, more than that to work, but you're also trying to hit a therapeutic dose range. And so sertraline ranges from 50 to 200 milligrams. And so if you're increasing even on a pretty fast rate at like 25, 50 milligrams a week, something like that, you can still imagine that it could take a couple of months. And then same with Prozac. Usually you increase 10 or 20 milligrams each week or every 2 weeks, and it can take a good amount of time. Usually, like when someone comes in and they've never tried medications, I would be very upfront about that it might take time to dial up and down and find the best dose range for you. So to not give up just because you're not feeling better in a week or two. All good things take time, right? So we do have to like really be upfront about the patients that this requires. So exactly to your point, sometimes that's not going to cut it. There are, so many symptoms. So there are other medications to bridge that gap so that you do feel better in the meantime, waiting for the SSRIs to kick in.
Yep, absolutely. And another similar category of medication is the SNRIs, the serotonin norepinephrine reuptake inhibitors. Those are both more commonly used, but not necessarily more effective than the SSRIs, especially in patients where the trauma involves some degree of pain or discomfort. One of the SNRIs, Cymbalta, is commonly used for chronic pain management. We know it's similar to SSRIs and can help with PTSD. Maybe it's a perfect fit. Unfortunately, sometimes that sort of logic doesn't necessarily hold up all the way in studies. And the SNRIs are not shown to be any more effective than the SSRIs for the treatment of PTSD. My experience is that one potential side effect of the SNRIs, because of norepinephrine, is some people can experience elevated heart rate, elevated blood pressure, and an activated feeling, which can, in a way, mimic the response to trauma. And so some people actually have kind of a negative response to SNRIs. Plus, it has withdrawal symptoms as well, similar to Paxil. And overall, in adolescent patients, interestingly, the evidence for SNRIs for the treatment of depression or anxiety in adolescence is not that great. It's not as good as SSRIs. So I would say it can be second line. It can be sort of in the mix, but I think starting with the SSRIs is generally the most recommended course.
Yeah. So the next category of medications we like to talk about are the alpha-1 adrenergic antagonists. So these are medications like prazosin or prazosin, You may have heard of them. We use them pretty widely, especially in PTSD. I will say that usually we start at a low dose, like 1 milligram, and we work our way up to about 4 or 5 milligrams. But with very severe trauma, especially in the VA population and the military combat population, we hike it up to 10 milligrams or even 15, 20 milligrams at bedtime to target those nightmares associated with PTSD.
That's exactly what I've seen too. And one particular thing about prazosin or prazosin that people don't fully grasp is that it's not a sleep aid. It's a medication that has a very specific indication to help with nightmares and recall events from trauma, but it does not necessarily help you fall asleep or stay asleep. So I've seen a lot of people conflate those two. Like, I have trouble sleeping. Oh, because I have nightmares, we'll try prazosin. Well, I'm not having nightmares, but I'm still not sleeping. Well, let's increase the dose. That's not going to help. It's really just for the nightmare component.
Yeah, that's an important point to make.
And I think that one overarching guideline for PTSD that I've always been taught is that a lot of the sleep medications will make you unconscious, but what you really want is that natural restorative sleep. So we typically avoid medications like Ambien or benzodiazepines or other sort of dedicated sleep aids. So this is a different category, even though it's in sort of the sleep world. This is something that's not only commonly used, but pretty specifically used in PTSD, where a lot of other sleep medications are not.
Mm-hmm. And along the same lines, we have something called beta blockers. So people might be familiar with propranolol, which is the most common beta blocker, non-selective beta blocker that we use in psychiatry. This medication has been studied pretty extensively, especially in its role of blocking memory reconsolidation and reducing the physiological arousal. So, what happens when trauma affects you and you have an intrusive symptom like a flashback or a nightmare? Your blood pressure goes up and your heart rate goes up. And in response to that, your anxiety and distress goes up. And then that also increases your blood pressure again and your heart rate again. And so, a beta blocker will break that cycle and it reduces the physiological response to that traumatic experience. What's really interesting is that we have mentioned before that traumatic memories are stored kind of differently. So it's stored within the default mode network, including like the posterior cingulate and hippocampus, that gives you that sense of self, the self that's relaxed, maybe browsing, maybe reading, just being your intrinsic self. When a traumatic memory is embedded in that intrinsic self, the default mode network, it's like you're reliving that experience over and over again. You're not just recalling something, you're full body immersed and reliving that trauma. So it's very, very painful. And the aim of the beta blocker is to block that memory reconsolidation and reduce that painful symptom of that traumatic experience.
Yeah, it's the core of the idea of the flashback, that you feel like you're back in that experience. That is a real biological phenomenon that we understand why that happens, where that comes from. Now, I think an unfortunate outcome of our research is sometimes we have a great theory about how something will work and why something will work, and then we test it and it doesn't work. And I think propranolol, to an extent, fell into this bucket, because if this works so well at preventing that memory reconsolidation, or sort of altering it in a way so that you can do the narrative exposure, the self-exposure, without experiencing the physiological arousal that accompanies it. Maybe you can use this preventatively. If you're going into a situation that could potentially expose you to trauma and you use propranolol, or you've just been through that experience and you use propranolol to reduce that physiological response, maybe you prevent this sort of different formation of memories to begin with. Great theory, does not work. There have been many unsuccessful trials of this post-exposure administration of beta blockers of different types, including propranolol, and it does not seem to alter the odds of developing PTSD afterwards. So good for treatment, not necessarily useful as a preventative.
Yeah, it's unfortunate, but it is an important study still. We need negative studies just as much as positive studies. That's how science works. Yeah.
Yeah, it's one of the biggest powers of science. We come up with these great hypotheses, but then we have to test it because sometimes logic plays out in the real world and sometimes it doesn't.
Yep. So next up, we have the category of second generation antipsychotics. These are medications like risperidone or Risperdal or Seroquel or quetiapine. You may have heard of those too. We really only use them in cases of severe agitation, really severe anxiety associated with trauma or mood instabilities. We try not to use antipsychotics too much because of its potential side effects like increase in weight and appetite and sedation. And so, as you can imagine, with trauma therapy, you don't want to be sedated. You really want to be able to sit through all of your emotions. So these are more second line, but certainly there's a place for them, especially when there's severe agitation or mood instability. So out of the second generation antipsychotics, it does sound like risperidone has the best evidence for augmentation and effectiveness. And quetiapine has shown some efficacy in monotherapy for PTSD, especially if the patient is a veteran. But overall, because of the risk of high drowsiness, sedation, somnolence, the clear benefit of antipsychotics use in PTSD is still a little bit unclear. So I'd say it's more like patchwork to use antipsychotics.
Yeah, I think that's a good way to think of it. It's symptomatic benefit. It doesn't help the core syndrome of PTSD like some of these other medications do, but it can help symptomatically, certainly in a less harmful way than some of the other agents that are commonly used, benzodiazepines, for example, but not necessarily really addressing the underlying issues. And as long as we're sort of on the topic of agents that can cause sedation, trazodone is another common agent, traditionally an antidepressant, but can be preferred for sleep initiation as opposed to sleep maintenance because it's highly sedating, but it's non-addictive, non-habit forming, doesn't have a lot of the side effects of some of the other agents. It's been tried in PTSD for addressing insomnia, addressing difficulty with falling asleep, but in studies, there was also some evidence of increased risk of suicidality. I think it's commonly thought of as a sleep aid that's non-dangerous in a number of ways, and people just sort of throw it on. But I think it's worth a little more caution in this population.
Yeah, absolutely. And because trazodone affects the serotonin system as well, we do know that all SSRIs and all antidepressants have a black box warning label for increasing suicidal ideation. So it is something to be very careful about and to check in frequently with your psychiatrist about.
Yep. There are other antidepressants and antidepressant categories that have been evaluated. So tricyclic, some of the older antidepressants are really not seen as preferred for patients with PTSD. They can be very useful if somebody has comorbid or pre-existing anxiety disorders, but if it's really the onset of PTSD itself, doesn't seem to be that beneficial. Same with MAOIs, another older or more reserved class of medications. There's a newer medication, zuranolone, that's a GABA regulator. It's being studied for PTSD. It has been FDA approved for postpartum depression. It's the only medication that's specifically approved for that. So jury is out. And then as we get away from antidepressants and more into the mood stabilizer category, Lamictal or lamotrigine is an anti-seizure agent that can be used as a mood stabilizer. There's some evidence for efficacy in PTSD symptoms, but it's not robust. It's not statistically significant. Topamax, interestingly, topiramate, is a medication that has a number of uses in psychiatry and neurology, and there is some evidence that it can be beneficial for PTSD. Really interestingly, it can be useful for people who self-medicate. So for people who have trauma symptoms comorbidly with increased alcohol use or alcohol use disorder, it seems to, independent of any other intervention, both reduce PTSD symptoms and reduce drinking by over 50% in some studies. Now, the studies are relatively small, but That's still a pretty robust result, even for small studies. All of the studies that I've found were in adults or adolescents. There was one study in adolescents that seemed to suggest that it might be particularly effective in adolescents with disruptive behavior disorder, oppositional defiant disorder, or conduct disorder, and PTSD.
Yeah, I do really like Topamax. It's quite helpful when you run through kind of your first line and some of your second line and you're kind of in a pickle. It's especially helpful, I find, for people with a lot of mood lability and with that, binge eating or some sort of disordered eating, because it does have that appetite suppression. Binging or purging is part of that escapism to food that a lot of people with trauma might resort to. So it's almost this link between dissociation and binge eating that can be very maladaptive. One caveat to Topamax is that it can cause cognitive slowing or fogginess, and so we have a name for it. We call it Dopamax because it makes you feel doped up. So I do find that starting at a low dose and titrating it slowly makes it more tolerable. It's also additionally helpful with migraines and headaches, which is often associated with trauma and sexual trauma. So there's a lot of things that Topamax can do if you use it right.
Yeah, absolutely. There are some non-medication treatments that are being investigated that are more considered sort of procedural psychiatry, or some people say interventional psychiatry, sort of like interventional radiology. So transcranial magnetic stimulation does have pretty decent evidence for efficacy in PTSD, but because of cost factors interfering with life and daily routine factors, it's not widely implemented for this. Vagal nerve stimulators, VNS, and stellate ganglion blocks have similar mechanisms of action of some of the beta blockers and the alpha agonist antagonist medications that we talked about before. They sort of reduce sympathetic load and have some promising data, but no real, that I'm aware of, and data changes all the time, but no real solid studies in PTSD treatment yet. And then there's also neurofeedback, which is used pretty commonly for ADHD, for cognitive function, that has some evidence for efficacy for PTSD. And we're getting into the more experimental, I would say, or currently being investigated treatments. So ketamine, which is increasingly used for depression, for suicidal ideation, does have a couple of positive controlled trials with resolution of symptoms for PTSD. One caveat is that ketamine can also be a dissociative agent. So for people with PTSD with prominent dissociative features, it could be either not a consideration or even contraindicated.
Yeah, it's interesting because Spravato, which is the nasal spray form, and the pill form of ketamine, they are not considered as effective as the IV form. And so I do make it a point to tell people when they ask me that the most evidence and the randomized control trials are based on the IV infusion, which involve much higher concentrations of ketamine than the pill or spray form. And you also have to couple the ketamine treatment with psychotherapy. Since ketamine is a psychedelic dissociative agent, it's really important to support that deeply ego dissociating experience and reflect on what you went through.
Yep. And then there are ongoing trials of psilocybin for the treatment of PTSD. And there is a strong push even amongst first responders, police organizations, military organizations for more research into this, because colloquially or experientially, people say that it can be pretty impressive.
Yeah, I guess the whole, psilocybin, MDMA, concurrently used with therapy to treat trauma and PTSD, that's been a huge area of research, promising, but also has some setbacks with like poor studies. So I was just wondering if you had any thoughts about psychedelics in kids or adolescents. My experience has been that we just don't even really talk about it. I think I've had one person ask me, but it's not something that I bring up at all, even for treatment resistant kids.
I think the history of that is mixed, and so it makes me cautious about the future. I do think that it's in the Hippocratic Oath. Our first responsibility is do no harm, right? And we know less than we know. And I think there are certainly experiential stories of people saying, I did one experience with mushrooms or psilocybin, and it really helped me reintegrate my trauma, and I haven't had a PTSD symptom since. Or I went on an LSD trip and I was able to communicate with my past self and take care of that part of me. And since then, I've been able to move forward. I do know that in all of the trials that I'm familiar with, therapy is an essential component of that research. So it's not just you take a pill of hallucinogen X and then you're good. It's sort of a guided experience with therapy. So I think it's really best thought of as therapy with augmentation, not just the treatment with the chemical. The history of ecstasy, the history of LSD, all started that way with the idea of using these to help unlock therapy. And the research has been mixed on that, both in terms of is it independently helpful and does it cause harm? Because I think there is a real risk of harm for some individuals who are at risk for psychosis, for dissociation, for worsening of their trauma, or getting stuck in a bad trip, or re traumatizing themselves. So I don't want to sound overly conservative, but at the same time, I kind of pride myself on being evidence-based in my practice, and the evidence isn't there to be able to recommend these things. So that's essentially what I tell patients, that if you want to look into studies, I'll help you. If you are interested in participating in supervised trial experience, I'll tell you how to find those. But I'm certainly not going to be able to recommend for or against it just because I don't know enough. The one conversation that I will have is the medications that they are taking and how that could interact. And I do talk about the therapy that they might be undergoing and how that could be maybe not a good combination. For example, EMDR can be contraindicated in people who are prone to dissociation. And if you're taking a dissociative like ketamine or a hallucinogen, then that could be problematic. And I do tell people that if they bring up the idea of ayahuasca, in particular, just because that can be an extremely potent, essentially MAOI, that can be very dangerous if you're taking an SSRI or another antidepressant medication. So I'm more concerned about the risks of these sorts of things. I'm not certified in EMDR. I'm not certified in the administration of these chemicals, but I say you gotta talk to people about that. Like, tell your therapist you're doing this. Tell the people who are administering the medication you're doing that, so that everybody knows what is going on. Let your care managers manage your care.
Yeah, 100%. I think also what you're saying about please be honest with us. We're not here to judge because, yeah, maybe there's some debates out there about what's effective and what's not, but it is important for us to know so that we can monitor for potential adverse effects, safety issues. Going back to some of these psychedelic medications, it is interesting because some of the things that I've heard about what it does is that it puts you in this space where almost like your ego dissolves. And so you're not clinging to this painful experience and immersed in its emotion. You can actually walk around it and have an objective look at it and process it. And so if we're talking about ego dissolution or dissolving in an adolescent or a child, that could be quite dangerous. It could be very disorienting. So I think like conceptually, and this is me just kind of speculating, thinking out loud, but the conceptual mechanism around that is unsettling. But I do think adults who have had really transformative experiences with these substances, certain medications, I think it is helpful for them because it kind of takes you out of that, the grip of whether it's anxiety or trauma or depression, just takes you out of that so you can have an objective view of what's going on with you. Not saying that we are against it by any means, just that we are very cautious, and rightfully so when people's lives are at risk.
Absolutely agree. That's fascinating. I never put that together, but the idea of ego death in someone whose ego is forming, that sounds risky. Yeah, that's an excellent conceptualization.
Yeah. Speaking further of things that could disrupt the healthy formation of memories, thoughts, and your mind's ego processes, benzodiazepines we actually do not recommend for people going through trauma therapy. There's actually been evidence that benzodiazepines have a negative impact on trauma processing and trauma therapy. It's been shown to have interruption of those normal, healthy memory consolidation. So we really do try to avoid it, especially in kids. It's actually shown to numb things out so much that you are not able to process anything or retain things. Whereas compared to alpha agonists, antagonists, and propranolol, they sort of dampen the physiological response, but it doesn't completely numb you out. So there's a big difference in the way that benzodiazepines work. I find that when someone comes in, usually they're already on a benzodiazepine because maybe they've been taking it and it's been relieving symptomatically, but they say something along the lines of, well, I have more anxiety now. It's almost like that impending doom is bigger when I'm off of it. So there is that paradoxical reaction that happens as you take more and more benzos. It can feel more and more hopeless sometimes.
Yeah, in a way, I had one patient describe it as feeling very unfair, and I get it that a medication that should, when you're suffering so much, make you feel better quickly, and yet really leads to many more problems than it solves. It's a struggle for somebody who maybe has gone through a traumatic experience and found even brief moments of respite from those feelings. They can be reluctant to give that up, even with the promise of, look, you're going to feel better in the long run without these chemicals, without these medications. It's a hard discussion to have. I get it. It's you want me to feel worse just so I can feel better maybe someday. I don't want to, I'm not interested in that. But all of the evidence that we have shows that the benzos make anxiety worse in the long run, make sleep worse in the long run, disrupt sleep architecture, pause the healing process. They're just not good chemicals to use in PTSD.
Yeah, absolutely. All right, a couple more. Let's talk about stimulants in the context of PTSD.
Oof, that could be a whole discussion. So, we'll first talk about stimulants in the treatment of PTSD. So, I think for someone diagnosed with PTSD, stimulants we know from various military research where unfortunately stimulants are used not necessarily for ADHD, but they can be abused. They can be used as performance enhancers. They can be used honestly just to keep people awake. That's kind of the history of stimulant use in the military. We know that people who use stimulants, especially at higher doses, higher than the doses that are typically used for ADHD, are more likely to develop PTSD after a traumatic exposure. So there's something about that that destabilizes the way that your brain naturally processes and heals from trauma and seems to encapsulate. I mean, that's, if you think about it, that's part of the fight or flight response. You are designed to go into quote unquote bullet time and for things to slow down and be impactful and for you to store that information. It enhances that. So it can worsen the encoding of those memories in a way that may not be beneficial to the person who's experiencing it. The symptoms of PTSD can include things like hyperarousal, distractibility, being on guard all the time, that can look very much like ADHD. So I think especially in kids, anytime someone comes in for an evaluation for ADHD, a trauma history has to be part of that exploration because another phenomenon that we see is people who either have ADHD and PTSD or who have PTSD and then are misdiagnosed as ADHD. The thing that can be tricky about stimulants is that symptomatically, even from PTSD, some people can appear better. They can appear less hyperactive and they can appear more still and more attentive. Whereas underneath the symptomatic improvement, you may be worsening the syndrome. So it's a tough balance, even of kids, where a lot of times we'll lean more into teacher reports, parent reports, and people who say, hey, their homework's better, or they're paying more attention, or they're less disruptive. All of these external symptoms seem to be so much better, forgetting that it's also about how the kid feels.
Yeah. ADHD medications like stimulants will enhance performance overall. You're more productive, you're more focused, you have more energy, and you might seem better on the outside, but it doesn't mean that internally your trauma symptoms are better, because stimulants can disrupt the natural memory formation process and the natural trauma processing. So, for example, if you're having a flashback, and you're taking a stimulant which is activating and could be agitating, it could make that flashback worse.
Mm-hmm. I will say we've already spoken about this chemical, but if people are diagnosed with ADHD or PTSD, sometimes even in the absence of any other directions, it can be better to start with an alpha agonist, which has some evidence for efficacy in both conditions. So I've certainly had patients who have ADHD who are taking stimulants who then go through a traumatic experience. And we will sometimes, on careful symptomatic evaluation, switch from a stimulant over to an alpha agonist, even if it's for a period of time, and then restart the stimulants. That's one of the great things about stimulants is they can be on and off like that. You can do switches very quickly. I mean, I work with hospitals and sick kids a lot. If someone goes into the hospital for a procedure, you stop the stimulant for a few days and then you restart when they come out. It's pretty easy to do that.
So some other preventative medications that have been brought up, this is very interesting. Hydrocortisone. So giving a dose of 20 milligrams twice a day for 10 days shortly after trauma, ideally within 12 hours, can potentially prevent PTSD from setting in. And this is so fascinating to me because I think the idea of like neuroinflammation or inflammation is so big in trauma. I'm sure that if you talk to any rheumatologist, they have some understanding of how traumatic felt experiences translate into these inflammatory conditions. A lot of times rheumatoid arthritis or lupus or even something like migraines, there's a lot of correlation with that. And so the proposed mechanism is that it increases synaptic plasticity. So that's the communication between two neurons that is becoming more connected. And it also increases BDNF, which is a known anti-inflammatory compound. So it reduces that fight or flight adrenergic overload. Yeah, I mean, I think it's one of those things that we see clinically, but we just don't hear too much about in research. You really have to go empirically, like you see it, but it's hard to provide concrete evidence.
And I'm so excited about these types of research studies because we work together on the consult liaison service, right? And so we would frequently be called and hear this kid, this adult, this person just had a traumatic experience. Do something, like make them better. Keep that from affecting them. And the honest answer is we've tried that. We tried debriefing, we tried benzos, we've tried all of these things, and they either don't help or make it work. And sometimes you just have to let the natural healing start and provide support. That's the whole point of psychological first aid. But I fully understand, and I would be excited about having something that we could do to prevent the entrenchment of this trauma. And so I think hydrocortisone is very promising. I do think there are some positive studies on opioids, which honestly, I think no one really expected. But when you think about it, it makes a lot of sense that controlling that pain, that negative physical stimulus that goes along with the trauma, the traumatic exposure. And it's really not opioids for opioid's sake, it's pain control. But keeping the pain well controlled can really reduce both the traumatic experience and the entrenchment of that trauma.
Yeah, I remember when I was in training, there were a lot of people with sickle cell disease that would come in. And first of all, the sickle cell crisis is traumatic. It's just so overwhelming and painful, and you can't breathe. And so I think there's a medical trauma aspect to that. It was really emphasized to manage their pain, whatever it takes. The opioids, yeah, we're going to pump up that Dilaudid, but it is needed in that moment because that subjective experience of pain and lack of control is going to make the physical symptom worse.
Yep.
Yeah. The pain, which is at the end of the day, it is a perception. It's a perception of the mind. There are nerve changes, but sometimes you get into a car accident and you don't even realize you broke your foot because your mind is elsewhere. You're trying to call 911 and whatnot. And so the perception of pain and the formation of the trauma and the PTSD, it is all about protecting the mind, giving it a safety net, as much support as you can. And that way you can build that resilience, which I think the VA caught on to by trying to do preventative measures with CBT.
Right. Absolutely. It's true. It's taking care of the filter through which you experience the world. That's so important.
Mm-hmm. Right. So there is hope for PTSD and trauma. As always, we never lose hope in this line of work. So recovery is very, very much possible. In fact, most people recover with appropriate treatment and support. And the support part is really important. You can almost go through anything if you don't feel alone. And so finding a community, a network around you, and also a safe professional space where you can talk about some of your darkest thoughts and feelings without feeling like you're going to burden your family or friends, that's equally important. Yeah, so there's a concept of post-traumatic growth, which is identifying oneself as a survivor. So this concept emphasizes the psychological resilience after trauma, describing positive changes in self-perception, like I've risen out of this, I have struggled, and now I am back up. You can almost take a very philosophical, almost like a spiritual take on this, because it is very strength-based and it brings back that confidence and appreciation and gratitude. Gratitude is such a difficult thing because if you feel deficient in your needs, you're not going to feel grateful. You're going to feel resentful. But if you feel that abundance, then you can feel grateful. So to create that abundant feeling, like I have enough, I am enough, is the process of therapy. We see it every day in our work. I certainly do think that there is lots and lots of hope for trauma.
Absolutely true. And I think the fighting against the darkness, I don't know how else to say that really. And I don't want to sound sort of preachy, like someone is responsible for their own PTSD. That's not the point. But to empower people over their experience and give them a different way to conceptualize or think about their life story, right? It's the shift of perspective and working that it's an active process. And I think part of it is that when you go through something that feels so terrible, you can feel like you're the only person who's gone through it. Or you can feel like there's an element of it, even if it's only 1%, that is your responsibility or your fault. And so there's a lot of shame that's wrapped up in it. There's a lot of embarrassment that's wrapped up in it. And all of these live in the shadows. And so taking it sort of out of the shadows and discussing it with someone, a therapist, a psychiatrist, finding a group of people who also identify as survivors, people who gain strength from the experiences of their life can be really transformative.
Yeah, so well said. And I think I'll comment a little bit about the current state of things in this country does not help with that open, welcoming discussion of thoughts, feelings, differences, and opinions. So I just want to also say that, there are still people who really do care about having an honest and respectful and inviting space for that. I think that's just important for us to remind our community as a whole. I mean, I'm just seeing it in my work. Kids will come in and feel defeated. There's just this constant fighting and negativity and all of this. So I just want to remind people that we're working behind the scenes and not giving up on this inherently wonderful and warm nature of us as human beings to accept and live together in harmony.
That was beautifully said. I love the whole philosophy around that. I think that's exactly right.